use of Steinman pin in my practice, everybody must be laughing. What is he talking about Steinman pin? So this is Fritz Steinman who has invented this Steinman pin. Now up to 2.5 you usually call it as a K-wire, and above that we call it as a Steinman pin because structural configuration is same as K-wires. Available in sizes of 3 to 5 mm, 0.5 mm increment, and length near about 3 centimeter to 6 centimeter. So it's uses for skeletal traction as a part of external fixator, reduction aid in some of the fractures like calcaneal fractures, trochanteric fracture, supracondylar femur, and tibial fractures. I use commonly for skeletal traction, as you know, of trochanteric traction, distal femoral traction, upper tibial skeletal traction, lower tibial skeletal traction, and calcaneal skeletal traction. The most important when we were house officers and initial period, that was the treatment temporary skeletal traction for shaft and intraarticular fractures and tibia, and if at all definitive surgery required, it has to be converted into the internal fixation. So calcaneal pin while nailing of diaphyseal fracture, when there are no assistants are there, it is a best tool. It corrects lengthening as well as the rotation, and you can do a surgery with few assistant. You can use a calcaneal for better manipulation of a distal fragment in tibial nailing also. So common uses in lower extremity, calcaneal fracture reduction and fixation, trochanteric fracture reduction, supracondylar fracture femur reduction, tibial fracture while doing nailing, arthrodesis of ankle in a Charlie's unit, and for interlocking screw drilling I use. Now this is the X-ray of unstable transcervical fracture. It is a very difficult to reduce in such a situation. You see this CRM picture, just pass a small Steinman pin here and you will find that you can manipulate the distal fragment or the proximal fragment and just push this 3 mm Steinman pin as a reduction tool and for stabilization so that the further surgery can be done nicely. Another is a reduction of a cervicobasal fracture is the most difficult fracture to do by traction and any maneuver. Just go anterolaterally, push the Steinman pin inside, and then intrafocal manipulate the proximal or distal fragment. And then after getting the image properly in the AP and laterally, you transfix the fracture with the Steinman pin. You can see here, this is the transfixation of the fracture. So another example, this is a 2 Steinman pin method. You anterolaterally pass the pin into the fracture side. That is the most important. Then manipulate here and then. After reduction is there, then you pass another Steinman pin anteriorly so that you fix the fracture, and then you do any maneuver, adduction, abduction, internal rotation so that you can do a nailing. Another example, a very unstable fracture. Majority of the time, some of the fracture requires open retrieval because there is a translation of the proximal and distal fragment. Usually, the proximal fragment is flexed and distal fragment is sagged down. So that the same thing, intrafocal manipulation by a Steinman pin and putting the 2 pins inside, and then you do these are everybody is now doing it. It's not nothing new I am telling you, but this is how we have to keep the reduction ready and then anteriorly fix it. Another example, you can see how you are doing intrafocal manipulation, and then you just fix this fracture so that you can do with a minimal invasive treatment. Another example, you can see here, then keep these 2 pins together, and then again you pass the pins exactly. You can see here anterior manipulation, or you can see then fixing the fragment together and then procedure. So reduction of the fracture femur on a fracture table, it becomes a very difficult sometimes because the proximal fragment is adducted, distal fragment is abducted. You give any amount of traction and F tool also, sometimes it is very difficult. So use a blunt tip of a Steinman pin percutaneously like this, and then manipulate the fracture fragment, and over the reamer, you pass a guide wire like this, and then you can reduce the fracture of the shaft. Another most important is the distal locking of a femur by using a Steinmann pin. Drill bit often skids from the smooth and round surface of the bone. Hence, I use a pin to make a interlocking hole. You can see how it's there, and you can pass a this 3.5 mm Steinmann pin is required, and you can easily pass the interlocking bolt. Another, this is the needs. This is the most of the time if you do a long PFN or even in a fractures of the shaft of the femur, because of the mismatch of the configuration, there is anterior jetting of the this femoral nail. In that case, you cannot lock it like this because there will be a stress riser and you will make it a fracture at the tip of the nail. And therefore, you can do a translation of the nail by putting a needle, by putting a Steinmann pin inside the hole eccentrically, then depress the nail, and you can see here it is centralized. And after this, you do a first locking here. It is locked here so that you can remove, re-drill it, and nail centralization and locking is done. Another example is the most important. This is a comminuted fracture. We don't want to open. Do a suprapatellar, supracondylar nailing. Percutaneously, you can manipulate the fracture fragment, pass a Steinmann pin intrafocally, and then you will be able to bypass these forces of the quadriceps and then pass a guide wire. And you can see here, clamp it. This is the Steinmann pin, percutaneously passed. Reduction is kept. This is the clamp tongs. This is the Steinmann pin. This is the reamer. And you can go ahead with the multi-lock nailing. So distal locking of the humerus, it is very difficult to do a locking with the drill bits. I use mostly the 3 mm Steinmann pin. This is for anterior-posterior locking. This is for posterolateral, posterior-anterior locking of the humerus. I usually do nowadays posterior-anterior locking for humerus nailing. This is the use of a Steinmann pin in a proximal tibial fracture. Junction of the anterior 2/3 and posterior 1/3 of the proximal site of the tibia at the level of the fibular nail. If you pass a pin, it acts as a polar pin, and it also helps in the direction of the upward, better manipulation of the proximal fragment. And you can also, it helps in the reduction to direct the trajectory to the middle canal in the suprapatellar nailing. So there are so many examples. You can see a Steinmann pin as a reduction tool in the tibial fractures, because in the proximal there is apex anterior deformity, procurvatum, and valgus and varus. So pass a percutaneous pin like this, and then you start the surgery, and you will be probably will not be able to displace the fracture. Use of Steinmann pin in infrapatellar approach also of the nailing tibia. Reduction of the fracture by percutaneous pin, you can do it, see it in this. And then most importantly, what you do to direct this in the suprapatellar so that the guide wire will not go posteriorly and it will not hit. It is the most important thing, because in the infrapatellar nailing, it is difficult to guide the guide wire and reamer in an anteriorly proper direction. So it helps in the directing the guide wire. So that you can see here, this is the Steinmann pin, guide wire, this is the reamer, this is the, and use of Steinmann pin as a polar pin helps everything. Distal locking of the tibia, same thing, surface on the anterior part is smooth and slippery, hence with drill bit often skids. With pointed end Steinmann pin, very easy to locate. Most important to avoid the heat generation. So constant installation of the distilled water or saline and in the oscillating mode is the only answer. You can see, and also it helps Steinmann pin. You can see a distal locking, whether it is in the nail or not, and then you convert. Another most important, a percutaneous fixation of calcaneal and plaster for 6 weeks. Steinmann pin used to elevate the fracture, and percutaneous multiple planing. I do it. Number of X-rays I can experience. I have done hundreds of days. I have no regret. Steinman pin used to elevate the fracture, percutaneous multiple pin, plaster for 6 weeks, restore of near normal anatomy. I cannot guarantee that it will be as a surgical methods, but there are so many complications, and I do it percutaneously. I get a good result. Innumerable example to share with this, and I think everybody knows about it. So this is how it is. We can pass a percutaneous screws also through the calcaneal. So this also can be used as an external fixator that everybody knows it, and used in a channelless compression arthrodesis unit. This is the case of tuberculosis recently done, and you can use a Steinman pin as a arthrodesis device. So in conclusion, some complications are there. Iatrogenic injury to the vital structure. Therefore, you must know the perfection in anatomy. Pin tract infection, if there is a heat is generated, therefore pin should be used. It should be sharp, and there should be in the oscillating mode, and constant irrigation with saline and distilled water. Loosening and osteomyelitis, this lead to characteristic ring serous formation, should be the avoided, and it's a iatrogenic complication. Thank you for patience hearing. Thank you very much.